This is an interview by Patricia Staley of the International Catholic Committee of Nurses and Medico-Social Assistants with Rebecca Ose, PhD, Associate Director of Research for the Center for Family and Human Rights, commonly known as CFam. Welcome, Rebecca.
Thank you for having me.
We're going to examine the United Nations processes for determination of reproductive health services. So if you would, for clarity of discussion, what is meant by reproductive health services?
So that phrase is used in a variety of different contexts. When you're talking within policy environments, especially international policy like the UN, the typical standard for reproductive health comes from the 1994 conference that was held in Cairo, Egypt, the International Conference on Population and Development. And as it was established in that conference, reproductive health includes a whole range of services, including maternal and newborn care. It involves family planning, and it also involves abortion in cases where it's legal according to the national laws. So what Cairo did was it basically left it up to the countries to determine whether abortion should be legal or not, but then said where it's legal it should be provided safely. Now, of course, it's never safe for the child, but the idea was that it should be provided safely to the woman, to the mother, where it's legal, but it made no determination as to whether it needed to be legal. It didn't establish a human right to abortion. From our standpoint, the phrase reproductive health is a standard that is not acceptable in the sense that it doesn't provide for the protection of the unborn child in countries where abortion is legal. So it's good that it leaves it up to the countries as opposed to saying all countries should legalize it, but it's bad in the sense that it doesn't provide protections for the unborn child where abortion is legal.
Would you explain to us the methods that are used by the United Nations or its affiliates to determine the need for global reproductive health services?
So the Millennium Development Goals, which are just expiring, had a goal. At first it started out just having a maternal health goal to improve maternal health worldwide. Some years later, because of some political maneuvering, they added a second part to that goal, which was to ensure access to reproductive health for everyone. Now that word access is important. You mentioned need. Obviously, people who have access to things may not choose to use them, and how that access is measured can depend a lot on how the questions are being asked and who's asking them. Just to draw one example, there's a so-called unmet need for family planning that you hear a lot about at the UN, and that need is, basically based on surveys that are conducted in households where they ask women, are you currently using a modern method of family planning? And do you want to have a child in the next 2 years? And if the woman says she would rather space children beyond the next 2 years or she doesn't want to have any more children and she's not using a modern method of family planning, then she's deemed to have an unmet need for family planning. But when you go deeper and you look at the reasons why women choose not to use contraceptives, they vary greatly from, some women are very concerned about health risks, side effects. Some say that they don't think they're fertile or they have very infrequent sex. Others have religious or other objections to the use of contraception, they or their husbands or both. So there's a variety of reasons why people who have a so-called unmet need might have all the access they want, but they choose not to use it. So from the standpoint of advocacy groups, you often hear them talk about unmet need as if it were synonymous with lack of access, when in fact only a very small percentage of women with a so-called unmet need for family planning say that the reason they're not using it is lack of access. That's 4 to 8% as of the last numbers.
Now, cultural competence is an important aspect of nursing practice. Are there diverse views of contraception and abortion respected in the need assessments?
So I guess the short answer is that a lot of this need is determined by surveys, and these surveys are conducted at the household level. They're called the Demographic and Health Surveys, the DHS. That's the most commonly used version of that. And they need to have a certain cultural sensitivity in order to get into people's homes in the first place. So when they come into a home and they do household surveys, they will not ask, say, the teenage daughters living in the house about whether they're using birth control or not. So their numbers on the unmet need for family planning are restricted only to married women of reproductive age. So there are certainly some cultural sensitivities that need to be in place even to be able to ask the questions. But in terms of what they do then with the data that's gained, certainly there's a large effort to try and change cultural norms around family planning. There's a lot of talk of creating demand for it. And so in places, for example, where a lot of women are saying that their husbands and possibly themselves also have objections to the use of family planning for religious or ethical reasons, there's a push to try and introduce methods that a woman could use without her husband's knowledge. Things that would be easier to hide, like an injection or an implant, as opposed to something that has to be used on a regular basis. And so, in that sense, there's attempts to try and get around or work, beneath existing cultural norms and to change them where they can.
In examining a UN-published bar graph called The Legal Grounds for Abortion in Developing and Developed Regions, it is noted that developing countries have vastly more restrictive abortion laws. Is the UN attempting to influence life-respecting nations to legalize abortion? How are they approaching that topic?
Sure. Well, one of the things that you hear often is that in countries where there are a lot of restrictions legally on abortion, the rate of women dying from botched abortions or complications of abortion are higher. But that only tells you a part of the story. As you mentioned, it's countries that are developing, countries that are poor, countries where health and other infrastructure is lower, where women are dying from abortion-related causes. But what you see when you look at the numbers is that women are dying at higher rates in those countries from all the different maternal causes, whether that be hemorrhage, sepsis, obstructed labor, etc. And when you increase the standards of health care and when you have better paved roads, access to health services where women can get to a clinic when they need emergency obstetric care, you see maternal mortality from all causes drop. And the evidence that the laws are not, on abortion are not the important thing. You look at countries like Chile, which is a regional leader in maternal health. You look at countries in the European region like Malta, Ireland, and Poland, which have a lot of pro-life protections in their laws, and maternal health in those countries is good. So whether women are dying from any maternal cause, whether it's abortion or anything else, is much more dependent on the region of the world that you're in and the development level and the level of infrastructure, and much less to do with the abortion laws. So changing the laws to make abortion more legal and more available on demand doesn't give you better maternal health. But if you have better maternal health, then no matter how pro-life your laws are, women will not die at the same rate. They will, they will have access to the services that they do need to save their lives.
Presently, are you aware of requirements of informed consent for any or all of the reproductive services provided by the UN or its affiliates? And that would be for the clients.
Right. Certainly the World Health Organization would say that informed consent is very important. The question really is, how is that applied on the ground? What information is given? Certainly when the World Health Organization, for example, talks about different types of contraceptives that are known to have some very serious potential side effects and risks associated, what they will often say is, well, yes, there are risks, but these risks are small compared to the risks of, for example, getting pregnant and going through childbirth, especially if you're in a region where childbirth is not safe. And so how the information is given to you, how that information is presented to the patient can really vary. Even if you're being told the risks, you may be told those risks against an even greater risk on the other hand. So
I'd like to have an assessment of the evidence of health benefits and or health detriments in women receiving the health services from the UN or its affiliates. We understand as nurses that fertility is an integral part of the total self. Teaching people to understand fertility and the life cycle development from conception to adulthood is a primary task of all nurses. There is a concern, though, that the primary method of fertility control promoted by the UN and many developed countries is fertility suppression by hormonal manipulation using estrogen or progesterone, both being class 1 carcinogens. What evidence do you have, or do the studies show, as to the global health consequences of fertility control by suppressing the hormones of a woman?
Well, there's several different angles to look at there. For one thing, there's the question of, does the woman actually really even want these interventions at all? Is she saying that she wants, when she says on a survey that she would prefer not to have another child in the next 2 years, essentially that's all other things being equal. There's no follow-up question saying how big of a problem it would be for her if she found out she was pregnant, or how happy she might be to find that out. And so some women are much more motivated to want to avoid pregnancy than others. And, openness to life, even if you're not, trying for a child at that moment, is not taken into consideration at all. So it's, any woman who says she'd like to space births and is not using a contraceptive is treated as if she has a demand for this. And so since that's the way it's being framed, I think a lot of health providers may be thinking that this is something they should be promoting to women, even if the woman is not motivated to use them or has health concerns. Another consideration is the fact that in countries that are poor and developing, there's a big push to put people on longer-term contraceptives, or contraceptives that might carry more risks, that are used at much lower rates in the developed world. And so there's a question of equity there in terms of whether the more dangerous methods are being promoted in places where there's, on the one hand, less choice involved, and number two, the risks are more likely to have more long-term consequences. For example, if a particular contraceptive increases your risk of bone density loss or of different types of cancer, if cancer screenings and osteoporosis screenings are not routinely done in those countries, those health effects are going to be much harder to manage, and there's much more likely that the women will die of causes related to those issues later, further down the road.
Has there been an acknowledgement of the data indicating the very serious negative effects you speak about, especially with Depo-Provera, such as increased risk of poor prognosis, triple-negative breast cancer, blood clots, stroke, or heart attack? I might mention that Depo-Provera, one of the hormonal agents that is used to suppress fertility, has a black box warning to it. So is there an acknowledgement that the data shows that there is harm being done in the women who are receiving these services?
Well, these studies that show these increased risks are sometimes acknowledged alongside other studies that show different outcomes, and so it's always presented as being in dispute and an unresolved area. However, there's a lot of political interest in trying to roll out these contraceptives, especially in developing regions, and there has been a lot of political discussion about whether the black box warning should in fact be removed. There's a petition in the United States to the FDA, the Food and Drug Administration or Association, to remove that. So it's definitely a political question as well as a question of research right now.
Talk to us about the changing methods of standards for abortion.
Well, the World Health Organization has been doing a lot to establish a new set of standards for abortion services worldwide. They recently, a few years ago, issued the second edition of their technical and policy guidance on what they call safe abortion. And the most common thing throughout that entire book is that increasing access to abortion worldwide is their paramount concern. And so to that end, they are promoting methods of abortion that would be deemed unacceptable in developed countries, that are at best second-tier approaches to it. They want to increase the provision of abortion, to increase the provider pool by expanding that to nurses, midwives, even in some cases pharmacists potentially, in the sense of prescribing abortion-causing drugs. And so this effort to create more providers of abortion by lowering the requirements to be an abortionist is a big part of that. Basically, trying to make the abortion-causing drugs more accessible on the ground, adding them to essential medicines list within the World Health Organization is another consideration. And also where the conscience rights of providers are concerned, trying to erode basically the protections of people's consciences in the healthcare world.
There is a movement of youth-centered health services. What would you say to nurses to be aware of when interacting with underage clients?
Well, certainly there's questions that would have to be looked at regionally and nationally with regard to reporting laws. If, for example, a girl who is below the legal age of consent for sexual activity approaches one of these youth-friendly clinics asking for contraceptives, abortion services, or other sexual-related services, particularly if she is sexually active with somebody significantly older where statutory rape laws might be being broken, there's a question of, is there a reporting requirement on the part of the healthcare provider? Do they need to report this to the local authorities? Could they face legal trouble for providing these services to an underage person without parental consent? Or on the other hand, could they face problems if they refuse for reasons of prudence or conscience to provide these services? And so it becomes very important for the doctors and nurses involved to know what their obligations and rights are under the law and to make sure that the right protections are in place.
Dr. Oss, are you aware of global conscience protection for healthcare providers who are opposed to providing harmful methods of treatment, or those who are morally opposed to contraception and abortion?
Well, this deals with issues in the human rights world. Certainly the Universal Declaration of Human Rights, which is one of the founding documents of the UN, stresses the importance of the right of conscience and belief on the part of all people, and that would include healthcare providers, certainly. The right of person to have the highest attainable standard of health is sometimes held up as being in opposition to that right. So, for example, the World Health Organization, in their technical and policy guidance on abortion, will say that yes, consideration should be given to doctors and nurses who, have an ethical problem with doing abortions. However, the right of the patient to have access to that service essentially trumps that. So if you can, in a timely manner, refer to somebody else who will do it, then you're off the hook, essentially. But if there's not a way to quickly and easily refer that person, then you have to provide the service. And so if you are a nurse or a doctor who is in that position, your rights are essentially trumped by the patient's demand for that service.
Dr. Oss, thank you for helping us understand global policy as it meets nursing practice in our world today.
And thank you for all the great work you're doing.